Hello guys, welcome back to Clinically Clear. So today let's cover another extremely important communicable disease, that is typhoid. Now this page looks very scary, but let me just break it down to you. So agent factors, host factors, environment factors. Agent factors. What is the causative organism? Salmonella typhi, most common, but also due to Salmonella paratyphi A and B, possible. Three antigens they have. H antigen, also known as flagellar antigen, so it is a motile bacteria. O antigen, also known as somatic antigen, and Vi antigen or the V antigen, also known as the virulence antigen. This is not that important. Remember this much, it is enough. Salmonella typhi, most common. Paratyphi A and paratyphi B. Mode of transmission, typhoid, as we all know, fecal-oral mode of transmission, contaminated food and water, fecal-oral mode of transmission. Incubation period, 10 to 14 days. The source of infection, it is the feces or the urine of reservoir containing bacilli. This feces or the urine of reservoir that is consumed because it contaminates the food and the water and then consumed, leading to transmission. So the source is that. So reservoir is whom? Reservoir is again a human reservoir. Okay, only human reservoir. Typhoid does not infect animals. It is human reservoir. So you have clinical cases. Of course, people who have typhoid, acute typhoid illness, they are reservoirs. But in typhoid, carriers are extremely important. So these carriers can be of three types: convalescent carrier, temporary carriers, and chronic carriers. Convalescent carriers is between 1 month and 3 months. That is in the recovery phase. In the recovery phase, they are shedding bacilli in the feces or the urine. That is convalescent carrier. Temporary carriers is between 3 months to 1 year. That is in the post-recovery phase. Between 3 months to 1 year, the temporary carriers are shedding bacilli in the feces or urine. Chronic carriers, even after 1 year, best example, typhoid Mary. She was cooking food for many years together and she was continuously shedding bacilli in feces, urine, sweat, whatever. So these are all chronic carriers. So convalescent carriers, 1 to 3 months, recovery phase. 3 months to 1 year, temporary carriers, and more than 1 year shedding bacilli in the feces or the urine, chronic carriers. So these cases and carriers, they form the reservoir. So agent factors, typhi, paratyphi, 10 to 14 days incubation period, fecal-oral mode of transmission, the feces or the urine is the source, reservoir is the clinical cases, and the carriers. Carriers can be convalescent, temporary, and chronic. Environmental factors. When do you think maximum fecal-oral mode transmission occurs? That is contamination. Monsoon, when there's a lot of water, less hygiene, unsanitary conditions. But typhi, Salmonella typhi, the good thing is it is heat sensitive and it is sensitive to even simple disinfectants like cresol, phenol. So it is sensitive to temperature and simple disinfectants. But environmentally, unsanitary conditions, unhygienic food practices, all that will increase typhoid. Okay. Host factors. Who eats outside food, street food? Street food. See, contaminated food and water, think of, unhygienic food, street food. So 5 to 19-year-olds, adolescents, children, they tend to eat outside more, right? So they will be at risk. Typhoid cases, typhoid illness, more common in males, but carriers of typhoid are mostly females. This is an important point. Carriers females, clinical cases male. Immunity, if you see antibodies against the H antigen, then vaccinated. If you see antibodies against the O antigen, it is an active case of typhoid. If you see antibodies against the V antigen, then indicates it is a carrier. If you do not see antibodies against the V antigen, it is a severe case of typhoid. Very bad prognostic factor. But this is also not that important. Just remember these two more than sufficient. Then coming to the clinical features. Clinical features, first week you will have a very gastroenteritis-like illness. You will have fever, you will have abdominal pain, and you will have something known as pea soup diarrhea, which unfortunately is how the diarrhea looks. It looks like pea soup, so pea soup diarrhea. That is in week 1. Then week 2 is where you have the classical typhoid features like step ladder fever. That is, the fever will never return to baseline. It will, body temperature will increase, stabilize at a high level. Again, it will increase, stabilize, again it will increase. So, step ladder fever. Rose spots, salmon colored rashes on the trunk, on the abdomen. Relative bradycardia. So these are all the typical typhoid features that are seen in second week onwards. Okay. The complications of typhoid is intestinal perforation, fatal complication, and even worse is sepsis leading to multi-organ failure or multi-organ dysfunction syndrome, MODS. Multi-organ dysfunction syndrome, where you have liver failure, where you have acute renal failure. So multiple organs will fail suddenly due to sepsis. That is a fatal complication. And typhoid, always intestinal perforation is a very important complication of typhoid. So this is about the clinical features. Week 1, then week 2. Complications. Prevention and control. We want to eliminate the reservoir. Reservoir, how will we eliminate? By early diagnosis and treating them. Now, cases can be reservoirs, carriers can be reservoirs. First, let's look at the cases. Cases, you have to diagnose them first. You have various methods of diagnosis. In the first, BWIDSU, 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 first week, blood culture, investigation of choice. Second week, Vidal test. Third week, S for stool culture. And fourth week, U for urine culture. These are the classical diagnostic tests. But still, ideal gold standard is marrow culture. But we can't do bone marrow culture for everyone. Too invasive, too expensive. So blood culture is considered the investigation of choice for typhoid, not Vidal test, even though Vidal test is still used. Treatment. Prompt treatment you have to give. Drug of choice for typhoid, fluoroquinolones, ciprofloxacin, all that, fluoroquinolones. If not for fluoroquinolones, you can give azithromycin, second line drug of choice. That is also contraindicated. Then third generation cephalosporins like ceftriaxone, cefotaxime. Now many books give this as the first line. No, fluoroquinolone drug of choice. If not, then azithromycin. If not, then third generation cephalosporin. So you treated the case. Will you just give the antibiotics and send that patient home? No. You have to admit, you have to isolate in the hospital until 3 consecutive stool cultures come back negative. 3 consecutive stool cultures of the patient should come back negative. Only then you will let the patient go. Till then, isolation. And to prevent further transmission, disinfection of the stool and the urine. The patient, whenever the patient passes stool, passes urine, you have to add cresol, 10% cresol as a disinfectant for 2 hours. So disinfection of the stool and urine. So cases, what you will do? Diagnosis, BWIDSU, blood culture, Vidal, stool culture, urine culture. Gold standard, marrow culture. Treatment, fluoroquinolones, if not azithromycin, if not cephalosporin, third generation cephalosporins. Isolate until 3 cultures come back negative. Disinfection of stools and urine using 10% cresol for 2 hours. This is how you eliminate cases. Carriers, you have to first diagnose them. How? Again, stool culture, urine culture. Why? Because they shed bacilli in the feces and urine. So, stool culture, urine culture. And as I told you, V antibodies indicates carrier, presence of V antibodies. Treatment for carrier is a bit different. It is not fluoroquinolones. You will give ampicillin or amoxicillin along with probenecid, or 100% if you want to eliminate the carrier, just do a cholecystectomy, because the typhoid bacilli, they concentrate themselves in the gallbladder. So by doing a cholecystectomy, you are removing this carrier source, basically the reservoir of bacteria in the body. You are removing that and therefore eliminating that carrier state. Then you should also surveillance of the carrier. You have to make sure that they don't handle food, water, milk for others. Example, typhoid Mary, she was a carrier. She cooked food for so many people, gave typhoid to so many people. We don't want that to happen. So surveillance. Health education. You have to educate the typhoid carrier about disinfection, food, water safety, sanitation, all that you have to give health education. So carrier, diagnose, stool culture, urine culture, V antibodies. Treatment, ampicillin, amoxicillin plus probenecid, or 100% is cholecystectomy. Surveillance, make sure the carriers don't touch food and water for others. Health education about sanitation, food safety, water safety, etc. That is about eliminating reservoirs. Next, we want to break the chain of transmission. So what is the chain of transmission? As I told you, the feces is the source, the feces of the reservoir. This, how will it contaminate the food and the water? Through flies, F for flies, feces, flies, fluid, floor, fingers, Fomites are some other objects. So all these act as like a transport mechanism for these bacilli from the feces to contaminate the food and then transmit to a new host. So this is the chain of transmission. So what is the best method to break the chain of transmission? By forming sanitation barriers. First sanitation barrier prevents all this. Here it breaks the chain of transmission. Prevents bacilli from feces contaminating fluid, fomite, flies, fingers and floor. Second sanitation barriers prevent all this from contaminating the food. Simple. So you're putting two sanitation barriers to break the chain of transmission. Other ways are chlorinate the water more than 0.5 ppm, that can get rid of the bacilli. So water contamination gone. Pasteurization of milk so that milk does not have salmonella. Disinfect fruits and vegetables with potassium permanganate so that salmonella contamination is taken care of. So these are certain other methods: chlorination of water, pasteurization of milk, potassium permanganate, disinfection of fruits and vegetables. Then coming to immunization. See, immunization in typhoid is not that useful. You can protect the susceptible by giving typhoid vaccine, but the problem with typhoid vaccine is it has a validity of only 3 to 5 years and only 50 to 70% efficacy. So the best method of prevention is all this: breaking the chain of transmission, food water safety, eliminating reservoir by early diagnosis and treatment. These are all much better methods of prevention than vaccine. Okay, because such an expensive vaccine, not even part of NIS, only 3 to 5 years of protection and 50 to 70% rate of protection. Three main vaccines: oral vaccine known as Typhoid 21A, oral vaccine, and two injectable vaccines, that is subcutaneous or intramuscular, single dose of 0.5 ml, V polysaccharide vaccine and typhoid conjugate vaccine. Both are recombinant vaccines. As we know, polysaccharide vaccines are only given for age more than 2 years, because age less than 2 years, any polysaccharide vaccines antibodies will not form. So V polysaccharide vaccine only for age more than 2 years. Conjugate vaccine you can give even for age more than 6 months. Both these babies, in both these children, 0.5 ml, single dose, intramuscular, subcutaneous. These are the recombinant vaccines. Oral vaccine, it is a live attenuated vaccine, Typhoid 21A. Oral can be in the form of capsules, which you'll ask the child to swallow. A child less than 5-year-old will not swallow properly. So capsule only for more than 5 years. Liquid Typhoid 21A for more than 2 years. And here not a single dose. Oral dose, 3 doses on alternate days. First day, the next day break. Then third day, the next day break again. Then fifth day. So day 1, day 3, day 5, 3 doses oral. More than 5 years old, capsulated form of Typhoid 21A. More 2 to 5 years old, liquid form. It is a live attenuated vaccine. It is an oral vaccine, Typhoid 21A. These are all recombinant vaccines, killed vaccines. Polysaccharide more than 2 years, conjugate more than 6 months. Intramuscular subcutaneous 0.5 ml single dose. But immunization is also not the best method of prevention, as I mentioned. That is it for typhoid. Thank you for watching.